I'm going to discuss about the first one, about the cough, but I'm going to talk about the chronic cough. I'm going to outline my presentation. I'm going to discuss about the case patient I got while I was doing my appointment. After that, I'll move on to the cough and its classification and the how we are going to approach a patient with chronic cough and what are the causes, and I'll touch upon uh, some important case. How are we going to manage them? All right. First, shall we move to the... All right. You guys can see it, right? Hope you can see it, and you can...
Yes, we can see it.
Right, great. This is the case. It was Mrs. Somasiri, about 40 years old patient with learning disability. He came complaining of dry cough for 6 months duration. Although it was 6 months, it's like comes and go. He has several private practice and OPD visits for the cough. He complaining about dry cough with scanty amount of whitish sputum. There were no known triggers. It is not associated with hemoptysis. In addition to cough, he is having shortness of breath, which was NYHA class 3. He feels dyspneic when he is doing moderate exertion. There were no fever, but he is complaining of recent loss of appetite and loss of weight. He doesn't have a feature suggestive of gastroesophageal reflux disease. There were no history of childhood asthma or recurrent respiratory tract infection. There were no history suggestive of connective tissue disorder, or he doesn't give a history of joint pain suggestive of chronic arthritis. He is not aware whether he got COVID-19 infection, and he had 2 shots of COVID-19 vaccine. When we come to the family history, his father died at age of 56 years with lung carcinoma, fairy lung carcinoma. He's a person with learning disability. He can't remember, but according to what he said, I thought it's more suggestive of a lung carcinoma. He's a smoker who smoked about 20 bead, which is local cigarette, for about past 20 years. He's unmarried, live with his mother. He's a farmer. Actually, though, this patient came to the base hospital Homagama, but his hometown is in Polonnaruwa. He came to the Homagama to visit his relatives. He's a farmer by occupation, so there is exposure to paddy dust. He's not involved in poultry farming or bird rearing. There is no contact history of chronic cough. He's worrying whether this is a sinister problem, as he's unmarried, looking after his mother. So he's worrying whether it's a chronic cough because he knows that he is smoking, and he worries whether it might affect his work. This is the history so far. What are the differential diagnoses? Do you have any differential diagnosis in this patient? Well,
COPD?
Yeah, chronic obstructive pulmonary disease is a possibility, as he is a smoker also. What else?
Bronchitis.
Yeah, chronic bronchitis is a possibility.
TB.
Yeah, great. Because tuberculosis that we should not miss. Tuberculosis is a possibility.
Bronchiectasis?
Bronchiectasis is also a possibility. Yeah, yes.
ILD?
Interstitial lung disease, you said, right?
Yeah.
Yeah, possible. Yes.
Asthma also another possibility.
Yeah, Dr. Javinder, asthma is a possibility. Yeah, those are the things came into my mind when I saw the patient. Actually, this patient was came to the OPD, seen by another medical officer, and because that she's worrying whether there is any sinister cause, he referred to the family clinic. The patient was referred to the family clinic. I had to assess the patient. With the help of madam, we came into those differential diagnoses. This is the examination finding. He is a cachectic patient. BMI was around 17. There was mild pallor was there. Blood pressure is 110/70, pulse rate 96. He's not febrile. As he's a bead smoker, there was nicotine stain in his fingers, but no clubbing. There was no ankle edema. He's not dyspneic at the time. There was no tracheal tug. There was no exclusion muscle used for respiration, and on examination, they are bilateral upper zone post crepitation. So, do you want to narrow down your differentials now? Hello? Yeah, with this history and examination finding, we narrow down our differentials to like as you said, the pulmonary tuberculosis is higher up in the list, which we should not miss. Gastroesophageal reflux disease is also a possibility. There is a possibility non-asthmatic eosinophilic bronchitis, upper airway cough syndrome, allergic bronchiolitis, habitual cough, all are there. So these are the fine. So we thought of doing some investigation. We had these facilities available for us. We did the full blood count, which shows mild anemia with microcytosis. WBC count was 14,810. ESR was high. What do you think about now? What is the most striking diagnosis?
EP?
Yeah. So the possibility of tuberculosis. So we went further. We did the chest X-ray. This is the radiograph. You can see the bilateral upper zone involvement. And I discussed with the, we had the radiologist here. So I personally went there and I discussed with him. So the history, examination, investigation, and the X-ray findings are like 100%. This is pulmonary tuberculosis. So this is what we did. Patient was referred to the Kalubowila chest clinic after explaining everything. And we advised him how to prevent further spread. And we notified the patient to the Ministry of Health through MOH, our infection control unit. So this is the case. What I saw at my training period. So it triggered me to read around it. So I thought of reading about chronic cough because this patient is having cough for long duration, had visited several places. There was a bit delay in diagnosis, I accept. But I think we did good for the patient when we saw the patient. So I'm going to discuss about the cough. Cough is a protective reflex which is needed to expel any foreign bodies or any infective material from upper airway. It's a reflex, a complex reflex involving afferents and efferents and process central processing unit. There are several cough receptors, especially in upper airway and lower respiratory tract. They are very sensitive to chemical triggers and irritation and displacement of the cilia. But it's peculiar here because there are cough receptors in the pericardium, esophagus, diaphragm, and stomach. So these receptors can be activated by touch, displacement, acidity, cold, heat, and other chemical triggers. Afferents from vagus nerve, cough center lies in medulla, and there is control from cortex. There are inputs from cortex and efferent pathway to extract muscles through phrenic nerve and spinal cord. So there is a reflex arc. So if there is any issue involving this reflex pathway, we might have cough. Cough can be classified according to the duration, acute, subacute, and chronic. Acute cough, usually infective cough, less than 3 weeks duration. Subacute coughs are 3 to 8 weeks duration. If the cough is going on more than 8 weeks, we classify it as chronic cough. Right. A few words about acute cough. Usually acute cough are infection following infection or irritation, short lasting, like infection like common cold, COVID, like exposure to fumes, or it may be a presenting feature of a chronic condition like bronchial asthma, COPD, or heart failure. Even lung carcinoma, reactive airway disease can present as acute cough. When moving into chronic subacute cough, usually those are post-infectious cough. Like as we experience COVID-19 can the patient with COVID-19 can have prolonged cough, and pertussis is a well-known infection involving subacute going on till subacute cough. Chronic cough, which I'm going to discuss. Chronic cough is a cough which lasts more than 8 weeks duration. Cough is a common encounter at primary care, and it's documented that more women seek medical attention for chronic cough, and it looks like that females tend to have more cough. They cough more as they are having high cough reflex sensitivity. Peak age of onset is chronic cough is around 6 decades. These are the common etiologies: bronchial asthma and cough variant asthma, COPD, gastroesophageal reflux disease, give me 1 minute. Non-asthmatic eosinophilic bronchitis, upper airway cough syndrome, tuberculosis, and like peculiar situation like irritation of the external ear canal due to wax infection. I'm going to discuss later in the presentation. Though there are several causes, about 10 to 25% of chronic cough may remain as undiagnosed, and we can nomenclate them as chronic idiopathic cough. Right. Complications of the cough. Chronic cough can, even acute cough can produce severe post-acute vomiting. Following cough, there might be muscle pain. It might, if it's like whooping cough condition, they might end up with rib fractures even. It might induce or exacerbate hernia. There might be urinary incontinence, especially stress incontinence. And though we don't give much attention, chronic cough can give a negative impact on social interaction. So the patient might be socially isolated, then they might end up in depression. So for chronic cough patient, it's better to assess their psyche because they might be depressed. How are we going to approach a patient with chronic cough? Well, we have to assess the history. Thorough history is essential. Like in such patient, we have to assess everything. Character of the cough, the smoking history, environmental exposure, current environmental exposure, occupational or recreational exposures, we have to look at. And we have to look at the medication. We have to assess his ongoing medications or past medications, contact history. Like in this patient didn't give a history of contact history of tuberculosis, but there must have been a contact history. And we should not forget about red flags, which are hemoptysis, loss of appetite, and loss of weight in this patient also. That we have to think about malignancies and chronic infection, contact history of tuberculosis, and the smoking also. Examination, we need to do a thorough general examination, respiratory examination, and relevant systemic examination. Like the cough might be a result of a heart failure. So we have to assess the cardiovascular system also. investigations. We have to do the basic investigation like full blood count and erythrocyte sedimentation rate. According to the American Association of Family Physicians, chest X-ray is mandatory in patient with chronic cough. Other than the patient like non-smoker, not on ACE inhibitors, we have to do the chest X-ray. For chest X-ray, threshold should be higher up if the patient is pregnant or if it is a small child. We can delay the chest X-ray. Otherwise, chest X-ray is essential in finding the cause for the chronic cough. And now I'm going to discuss about the causes for chronic cough. Bronchial asthma. Asthma is a common cause of chronic cough. They will present as usual features of wheezing, bronchial asthma, like episodic wheezing, dyspnea. There's a diurnal variation. There is a variation of bronchial asthma called cough variant asthma. In such patients, they usually doesn't give a history of wheezing. They only give a history of dry cough. There is less mucus production and less shortness of breath. But there are triggering factors, aggravating factors, and relieving factors. And diurnal variation is there, but diurnal variation for cough, not for the wheezing or shortness of breath. So we should not miss cough variant asthma. In such patients, there will be family history of bronchial asthma, atopy, and they know what are the triggers. So we can ask about the triggers. Then the second, or like one of the common causes, gastroesophageal reflux disease. Like I was not aware about this one earlier, but my madam said that when I read about it, I found this one. It's so common. The gastroesophageal reflux disease can present as chronic cough. They might have other features also. Heartburn, sour taste in mouth, dysphonia. Sometimes, mind you, chronic cough, there might be gastroesophageal reflux disease leading to chronic cough, but there might not be any GORD symptoms in the patient. GORD, gastroesophageal reflux disease, because of the dysfunction of the lower esophageal sphincter. So the patient, the condition worse occur while the patient is in lying down position. The treatment is a lifestyle modification, reduce the weight, avoid heavy meals before bed, and anti-reflux therapy. So we can start a trial of anti-reflux therapy. The other condition is laryngopharyngeal reflux, which is also can cause chronic cough. In this situation, gastric acids move up to the laryngopharynx, inflaming the larynx. So when you examine, there will be redness over the laryngeal area. The patient might present with dyspnea, hoarseness, dysphagia, or repetitive non-productive throat clearing. It is suggested that this can occur due to dysfunction of the upper esophageal sphincter. The patient has symptoms like when the patient is bending over, doing Valsalva maneuver, or doing exercise. And the difference is gastroesophageal reflux disease is mainly the problem of lower esophageal sphincter. And obstructive sleep apnea patient also can present with chronic cough. 30% of patients with OSA have chronic cough. The reason for that is the gastroesophageal reflux. So we have to address the gastroesophageal reflux part also, and the treatment might involve CPAP. Right. Again, following bronchial, so gastroesophageal and laryngopharyngeal reflux conditions, the upper airway cough syndrome, earlier which was known as post-nasal drip, but now all the condition has taken into one umbrella term, upper airway cough syndrome. This is because of the excessive nasal secretion, which irritate the pharynx and larynx, which produce the cough. Non-allergic rhinitis. Non-allergic rhinitis, though it's said there are 8 or more subtypes. Non-allergic rhinitis with eosinophilia, atrophic rhinitis, senile rhinitis, gustatory, drug-induced, hormonally, like pregnant women might have rhinitis. These rhinitis can irritate the larynx and pharynx and produce the chronic cough. In such situation, the symptoms and signs are non-specific. There might be nasal discharge. They might be doing the frequent throat clearing. And sometimes they explain that they have a sensation of liquid flowing into the throat. So if the patient presents with a chronic cough and these symptoms, it is suggestive of upper airway cough syndrome. Examination, if you examine the pharynx, there might be cobblestone appears because of the irritation of the pharyngeal mucosa. Treatment involve antihistamine. You can use steroid spray and nasal decongestion. Leukotriene receptor antagonist has a role to play here. Right. Another cause for chronic cough, non-asthmatic eosinophilic bronchitis. These people also present with dry cough. This condition is more or less similar to bronchial asthma, but there is less sputum production. They have atopic tendency, but we cannot demonstrate this airway hyper-responsiveness, which is essential to diagnose bronchial asthma. The diagnosis can be confirmed by bronchial mucosal biopsy, where it shows highly prominent eosinophils, but it is not done. This is a clinical diagnosis. Treatment is same as bronchial asthma, inhaled corticosteroids, and it has shown that 1/10 of the people with non-asthmatic eosinophilic bronchitis later progress to bronchial asthma. Chronic bronchitis, as we all know, can you said it has a differential diagnosis also. Chronic bronchitis can present as a chronic cough. Chronic bronchitis is defined as the presence of cough and sputum production on most days over at least 3-month period for more than 2 consecutive years in a patient without other explanation for the cough. They produce whitish sputum, common among smokers and ex-smokers, but prolonged exposure to noxious gas can produce bronchitis-like symptoms. They usually doesn't have fever. Management of chronic bronchitis. Chronic bronchitis management, it's non-pharmacological and pharmacological. Non-pharmacological, you have to advise on stopping the smoking, pulmonary rehabilitation, regular physical exercise. Pharmacological interventions are, we can use bronchodilators, inhaled glucocorticoids, there is a place. Accordingly, we can use antibiotic or antivirals according to the situation. Right. As I said in the history also, some medications can produce chronic cough. So assessing the medication history is vital if the patient present with chronic cough. What is the commonest medication can produce cough? Hope you all are with me. Yeah, like AC inhibitors can produce. It's well known that AC inhibitors can produce cough due to accumulation of bradykinin. Other than its renin-angiotensin pathway, it affects the bradykinin pathway. So there might be accumulation of bradykinin, which stimulate the cough reflex. A few things to remember. Chronic cough can appear just after, like 1 week after the use, and it takes some time to disappear. It might appear as 1 week after use, or even 1 month or 2 months after the use also. So you cannot correlate with the starting of the medicine and appearance of the symptoms. So you might try to stop the medication to assess whether it's the cause. And if we restart the AC inhibitors, same or different AC class, the cough will reappear. The asthmatic and non-asthmatic have the same risk. So when we start AC inhibitor, we don't have to assess whether the patient is having bronchial asthma. Bronchial asthma, whether they are having or not, we can start. But if it appears, we have to stop it. Calcium channel blockers and bisphosphonates can produce, because the sphincter relaxation, because of the calcium channel blockers, it can produce gastroesophageal reflux disease, which in turn can produce chronic cough. And lateral prost eye drop, which is a prostaglandin F2 alpha analog, which can activate cough receptors in the nasopharynx, can produce cough. Timolol being a beta blocker may activate bronchial asthma. There were reported cases of sitagliptin producing chronic cough, but it's not well proven. So it's better to take it as it doesn't. It is not a drug which cause chronic cough. ARB does not cause cough. Right, as one of you mentioned, interstitial lung disease is also a kind of a rare condition causing chronic cough. It's characteristic because the patient is having chronic cough and dyspnea. And usually they are elderly patient, more than 60 years of age, with a gradual onset, progressively worsening condition. There might be family history. Rheumatic diseases can produce later can go into a interstitial lung disease. So they might have arthralgia, dry eyes, Raynaud phenomenon. The people who have exposed to the fume and dust, silica, occupational recreational exposures, prolonged exposures, they might end up with having interstitial lung disease. So we have to assess in the occupational history whether they have these exposures. When examining, you can hear fine crepitations in both lungs. This is a kind of a condition which needs multidisciplinary approach. We manage them symptomatically, treat underlying conditions, but these patients need referral, and it's a multidisciplinary approach. Well, we should not miss malignancies. As I said, if the patient is having chronic cough, loss of weight, loss of appetite, hemoptysis, we have to think about malignancies. But mind you, less than 2% of people with chronic cough might have cancer. So it's not common, but lung cancers are the commonest cancer. Lung upper airway cancers are the commonest cancer worldwide because of the smoking. Malignancies are common among smokers. As I said, they present with hemoptysis, shortness of breath, loss of appetite, loss of weight. Imaging is essential. This is a multidisciplinary approach. Then we come to the other patient. The patient is having tuberculosis. Like chronic infections can produce chronic cough, tuberculosis, aspergillosis, histoplasmosis, lung abscesses. These are common in immunocompromised patients. Tropical pulmonary eosinophilia is also a not a chronic infection, but it presents with the filariasis nematode infections. It can produce a chronic cough. And as we encountered COVID-19 patient, infected patient with COVID-19, they had a cough for more than 8 weeks, which account to chronic cough. Bordetella pertussis or whooping cough, they can produce acute cough, subacute cough, and chronic cough. They present with usually with this characteristic whooping. As you mentioned, bronchiectasis is also a cause of chronic cough. Cough with excessive sputum production. Bronchiectasis patient, like they have postural cough. When they turn from one side to other side, they might have cough, which is productive cough. There are peripheral stigmata of bronchiectasis. So the patients are usually the reduced immunity, recurrent infection, patients with other illnesses. We need imaging to diagnose the bronchiectasis. Aspiration can cause cough, especially the patient who are elderly patient with a cerebrovascular accident, bedridden patients, debilitated patients. Usually, like their carers, they don't like to put this NG tube for the feeding. They try to feed them while lying down or slightly upward position. They can have aspiration, which can have drastic effect. The characteristic feature is that they compare that when they are fed, they have this cough. So the aspiration, we have to think about the aspiration in such patient. Foreign body aspiration, especially in children, they might present with chronic cough. As we realize that trachea and upper airway, they have cough receptors. If there is anything foreign, it will continue to irritate the cough receptors, and they might have chronic cough, regular chronic cough. On examination, there might be focal wheezing, hemoptysis, foul-smelling sputum. Some part of the lung might have collapsed already, atelectasis, so we can identify by examination. And heart failure can produce chronic cough. Usually they have cough associated with dyspnea. It is because of the pulmonary edema. They produce pinkish frothy sputum. They have this orthopnea, shortness of breath, ascites, and they might have dependent edema. As I said, vagus nerve take the afferents from the cough reflex. So if there is disturbance to the vagus nerve, it might trigger the cough. Central airway compression, like if there is AV malformation compressing the trachea or retrotracheal masses which compress the trachea, it can irritate the vagus nerve and produce chronic cough. These are not so common features. These are rare conditions, but for the sake of completion and like those are interesting, I thought of mentioning it here. There's a condition called laryngeal sensory neuropathy, which is rare. They also have chronic cough and they have this recurrent throat clearing and laryngospasm. There's a funny thing called Arnold cough reflex, Arnold ear cough reflex. When there's earwax impacting the external ear canal, or if you try to remove it with a cotton bud, or if you irritate the external ear canal, it's a peculiar site where the cough receptors are there. So the cough receptors are triggered and there it might be cough. So it's better to have a look at the both ear canal if the patient coming with the chronic cough. Premature ventricular contractions can produce chronic cough, and there is a condition called Holmes-Eddy syndrome, where there is autonomic dysfunction of vagus nerve. They have this dilated pupil, slow light reflex, like abnormal deep tendon reflexes. It's right. I have come into the final part of the presentation. Chronic cough, I have discussed a case. I have given the possible common etiologies and kind of rare etiologies. After that, there are few conditions that we should diagnose by exclusion. Some people might present with psychogenic or habitual cough. The characteristic features are in previous situations. This cough usually the cough is there during sleep. It might disturb their sleep, and whatever the situation, whatever the occurrence, the cough is there. But in this situation, you can detect that usually the cough doesn't disturb their sleep. It doesn't appear during sleep, and if the patient is having pleasurable distractions, the cough might disappear. So we have to look for any other coexisting anxiety, depression, domestic violence, these things. As family physician, we have to keep an eye on those things. So in such situations, the health education, reassurance, and essential measures we have taken up. Behavioral modification therapy will help the situation. So I have come into the final components of the presentation. These are my references. So I think I have made some point. So it's time to question and answers and a bit of a discussion. During that, I want you to, I have posted a link in the chat box. If you could, it's a Google form. It doesn't take much time. It's for my academic purpose. If you guys can answer that, that would be great. Thank you. Prabhat.
Dr. Indra,
Yeah.
I have a question. Why didn't you do sputum AFB before referring that patient to respiratory visions?
Yeah, Dr. Tarang, it's really a good question. I think my madam will stand with me because when I discussed with the radiologist, because at Homogam we had every facilities, we did the full blood count and ESR and the chest X-ray. So this is 100% tuberculosis. It's like it was in the morning around 12. Already I kept the patient for about 2 hours to get these things done.
Yes.
So if I going to keep on the keeping patient, I might be spreading the disease. So we thought that it's the best action to do is to refer to the nearest chest clinic. So they will arrange everything because they have facilities. Otherwise, we might have delayed the treatment. Already it's
Okay,
delayed.
so avoidance of the delay. Yes.
Yeah.
Okay, thanks.
Pralad, that I did good question. What's the question?
Yeah.
What's the question? I couldn't get it.
What Prabhat asked, sorry, Dr. Tarang asked.
Yeah, I don't know. Whoever.
Yeah, Dr. Tarang asked, like, why didn't we do the sputum AFB prior to sending to the chest clinic?
No, if why we do the sputum AFP?
Madam, sorry, I
Madam,
couldn't.
to
I'm
confirm
asking
that,
the question back. Why we do the sputum AFP?
to confirm the diagnosis. Madam.
Yeah. So then if it is more likely, it's sort of, I mean, the next question, what is the percentage of positivity for the sputum AFP? percentage of positive. So suppose we will do sputum AFP takes about 3 samples there, right? Early morning 3 samples. It takes about 3 days, right? And now tell me how many sort of do you think the chance of positivity in those 3 samples?
It's very low, I think.
It's very low.
Yeah.
Suppose it's negative, then you'd keep the patient. That's the thing. So it's sort of a, like the patient with chronic cough, with that much of a, sort of, it had been there for months and months, nobody looked at it properly. And ultimately, that's why we personally went there to discuss about the x-ray with the radiologist. And he gave the options, it's because, not only the AFP, there are a lot of high, sort of investigations now available to diagnose tuberculosis, which is not available in a base hospital without a chest clinic. And the places where the chest clinics are, all the facilities are there. If Kalubowila, if they don't have all these facilities, they can communicate with the MRI and can do the best for the people. That's the reason I think if we don't have any other options, if it is not very pretty obvious in the chest x-ray, of course, we can wait for the AFPs, but still, though it is negative, sometimes we have to go for the next level of investigations. So that's the thing. Like if there's a one investigation, say it's more likely tuberculosis, what's the point of keeping the patient? If we can start, because sometimes, not all the time, we give anti-TB drugs with a suspicion whether it's positive or negative. Trial of anti-TB, it's not a big deal. So in several times in the wards, we used to give trial of anti-TB. But here, there's a high chance. I think it's a good decision. If we suspect and if we give some sort of a positive evidence of TB, we have to send the person to it's like a not referral, it's a coordinative care. And we always give the patients all the instructions. And we have the continuity of care with us. So the patient can come back to your station and discuss with you if the patient has any issue with the anti-TB medication or whatever the problems. So I think the answer for that question is that. Does that give the answer? I'm not sure it is the expected answer, but anyway, that should be the way.
Yes, madam. Yes.
What are the other? I want to say some other thing. I've noticed people try to leave the session just after the presentation is over. So what's the point then? Don't do that, because the discussion part is the most important. Because maybe there are it's like the brainstorm. One person is talking, and there are different perspectives. You can have different experience and different levels of knowledge, different places of working, and you can contribute and make a nice, very productive discussion. I think if you want to leave, better not to join. Don't you have any other questions? If you don't have, I'll ask a question then. There's a patient. I'm not saying the age or the gender. More than 8 weeks cough, that is chronic cough. And on like auscultatory, just I will be giving only the auscultatory findings. There are fine inspiratory crackles, like all the lung fields. How do you proceed? What are the differentials and how do you proceed? Except Lindrelal, others can talk.
Madam, does the patient has any history of chronic diseases like rheumatoid arthritis?
Yeah, there's a one now. What are your set of differentials in this patient?
Chronic
What are the
cough with
differentials in your?
fine crepitations. Chronic
Yeah,
cough with
this
fine
because in the last presentations also there. What's
yes.
I mean,
So,
yeah, what are
just the first thing came to my mind was interstitial lung disease, madam.
Yes, exactly.
Yeah.
It could be one interstitial lung disease. And what are the possibilities?
It could be due to lung diseases or cardiac problems.
Mhm.
And then
Lungs,
basal peps, isn't it? If it is cardiac, the peps will be usually it's
Now,
more base.
I let her to talk. Let her to.
for the respiratory causes, it can be it may be due to resolution of bronchial asthma, or like Supun said, it could be due to interstitial lung diseases. For the cardiac, I think mainly the heart failure.
Jamini, what else you can discuss? What are the instances you get fine like inspiratory crackles? I told you the physiology even. What will happen? Any causes?
A carcinoma of the lung.
Exactly, the interstitial lung disease. Yes, it's due to that. What are the other things? Any other thing? Any chronic infections?
Any chronic infections post TB leading to fibrosis also can lead.
Yeah, exactly. It could be that. What else? Now, the person comes, it's the same presentation here. Sometimes a reactivation is where it's not so common, but anyway, another new, like a reinfection, not reactivation. If you take reactivation and reinfection in TB, reinfection is much commoner, more commoner than reactivation. So it could be a lot of things. So then when you assess, so what's the next level now? You examine and these are your sort of preferentials, and then how do you proceed? Yes, Supun?
I would like to do chest X-ray, madam.
Exactly, for X-ray, we'll say, yeah, X-ray doesn't give much value, right? Okay, we can get some idea, of course, fibrosis and all, like the same, maybe diagnose this one. And what else?
If you are suspecting interstitial lung disease, best thing would be to go for a HRCT.
HRCT is the best option now. So then only now, if you want to proceed with HRCT, so there you have to gather a lot of information before you send. That's the thing actually I was waiting for. So the next option is to go for the HRCT. So you must have some evidence why you send for HRCT. So to gather a lot of information from patients. I think you better, I mean, it's good for a SCQ. Better like sit in one place. I'm talking to your batch, the super seniors. Better like, because you don't have much time and think and write. Okay, you better think what are the information I should gather. So these are the plus points and these are the things in favor of going for HRCT. You can each and every patient you can ascend, right? So I think, like you cannot close your eyes and tell everything because it should be very technical. You have to talk now. So then it's better you must have a good knowledge. This is why it's a very good stimulus for you all to like remember or revise or to get some new knowledge. I again to read some other more books or the articles or whatever. And I think the idea of having this type of discussions is that it may be helpful for your day-to-day practice, or it could be it will help you for the maybe SCQs, MCQs, or especially long cases and the huskies. So then you bet with the same patient we can use for all these three components, maybe as a husky or long case. It's the same kind of patient. This time we gave for your the research, same presentation, right? And then because it's either long case, the presentation is same, but our expectations are different. Even the OSCE, the presentation is same, but our expectations are different. The same way, the ski CQs. So when you get a case, you try to use like all the ways that how can I like proceed for each and every component. It's a sort of a homework for you all now. Don't waste your time now. You have to work very hard. Even the first 2 years, you have enough time. Try to do that. Then only you will learn. Otherwise, by listening and just like sort of referring the same slides again and again will not help. You have to actively have to do yourself, right? What are the things you can do? Today, I didn't hear Tarindra's voice. Why is that? Okay, now then what about the next session then? Next, we will be taking the next session now. At least Talkman will begin the next session.
It will be from the junior batch, madam.
ජූනියර් කියලා කියන්න එපානේ. වචන තියෙන 1 2 3 කියලා කියන්න.
2, like it's 2.
2 වෙන්නේ කොහෙද? ප්‍රිමාලි කරන්නේ.
It's a rotation, madam. Like, now all 3
Yeah.
batches are involved, so it will be the third one.
Third one is
Merger.
ජූනියර්.
Then the first one.
මොකක්ද අප්පා අවුරුදු ගැන කියන්න බෑ.
Dr. Manoj's batch, I think.
Year 1.
Year 1, yes. Sir.
කවුද ගන්න year 1 එකේ?
Udan will do, madam.
දැක්කද මනෝජ් ටක් ගාලා කිව්වා උදාන් වීඩියෝ. Manoj, I'm waiting for your presentation. මතක තියාගන්න මම මතක් කළා නෑ. උදාන්
Yes, sir.
උදාන්